So the patient's supine, you want to shave the right lower quadrant, prep it and drape it. Okay. So the important landmarks are the anterior superior iliac spine, the umbilicus, and McBurney's point is 2/3 of the way from the umbilicus to the anterior superior iliac spine. So it's about there. A gridiron incision would go perpendicular to that line. A lance incision is horizontal but also centered on that line. So we would be cutting about like that. So if you look at the base of the wound there, we've gone through the skin, the superficial fascia and the fat, and we can now see running from superolateral to infromedial the fibres of the external oblique. So we incise those with a stab incision in the line of the fibres. Look at a clip, please, a small clip. Take each leaf and a pair of scissors to score, bang a bit please, up and down. So you're scoring in the line of the fibres. Langen back in that corner please, Catherine, thanks. So now we're replacing the Norfolk and Norwich retractor underneath the external oblique. So underneath you can now see the fibres of the internal oblique running at perpendicular to the external oblique. So we can open that first of all just with a pair of scissors. Do you have the other Langenbecks there? And then this one. Now at the base of the wound now we can see some fibres running transversely. That's the transversus abdominis. So we can open those in the line of their fibres and then replace our Langenbecks into that plane. And then the next layer is the peritoneum. Often there's some preperitoneal fat between those layers. So we can open this, having checked there's nothing between finger and thumb. So we've entered the peritoneal cavity. You can see there's some serous fluid coming out. Now's the time to take a microbiology swab before it all spills out into the wound. So we now open the peritoneum widely. The best way really to open up this layer is just to stretch it with your fingers. You can take that. So we've now entered the peritoneal cavity and you've got a swab and a stick. Just clean this up a bit. I think we can see just below the surface some bowel. And that looks to me like cecum, or at least colon. And you can often tease this up with your fingers. I know it's colon because I can see the Taenia coli running down the wall with the colon. Now it's usually easier to take out the Travers retractor or Norfolk and Norwich at this stage, otherwise it tends to catch the bowel. So usually fingers and thumb can get the colon out. That's the key to getting to the appendix. And then just feel inferiorly and all around for any adhesions anchoring down the appendix. And my finger's gradually working around those now. There's a small bowel, so that's the ileocecal junction. So we know that the appendix has to be around here somewhere. Knowing my luck, it'll be a dreadful retrocecal one. So since that one wasn't going to behave for us, let's go to an appendicectomy my colleagues were doing. And this was a much more mobile, straightforward appendicectomy. And then we'll come back to the retrocecal one afterwards. So they've already opened the abdominal wall using a lance incision, just like we did a moment ago, and then now they've delivered what looks like cecum. You can see the tinea coli running along the length of the bowel, and they're using fingers and some Babcock forceps to deliver it out into the wound. And they've now caught sight of the beginnings of the appendix, that tubular structure, and the first thing to do is get control of it, and these Babcock forceps are designed to encircle that tubular structure. So they've encircled the base of the appendix, and they're trying to coax the tip out with a finger, and that's how it should go. Sometimes there are adhesions to break down, but it should be mobile enough to come out like that. And this is a horrible inflamed appendix. They're controlling it with 2 Babcock forceps, and then you can sort of suspend it up, and that displays the mesoappendix. Create a window in the mesoappendix, and then pass a clip in, trying not to catch the swab, and clamp off the mesoappendix, divide that. Sometimes you can do that in one go, sometimes you can do it in more than one go, depends how big and chunky it is. You can see this one's a really horrible appendix, pus is coming out of it. They're trying to protect the wound with the swab. So they're making another window in the mesentery, clamping that, and then dividing that.
You have to work towards that. Another swab, please.
Swab?
Yeah, small swab. Scissors, cut.
Is this going to be one where you use clips?
And then we're right up to the base of the appendix. That'll be the last mesenteric clip they'll put on. And final division.
That's it. I think that's it.
Just checking they're right down to the base.
You should not do
Now they're just tying the mesoappendix there, the clips they put on the mesoappendix, just with some absorbable sutures like Vicryl.
Thank you.
Now they're just holding out the appendix.
your diagnosis.
Do be careful because it can be quite friable.
Yeah, and up. Yeah.
So they clamp proximally and then distally, and then you put the tie or transfix around where you've just squashed the appendix proximally. And the distal one is to control the appendix and allow you to divide it without all the contents of the appendix spilling out, if it hasn't already. So here they're putting on one tie. You can transfix it. One tie can do, or here they put a second one on, and then cut that flush with the second clip. Send it off to histopathology. So now back to this slightly more tricky one. So once you see first sight of the appendix, try and get a Babcock on it, so we can see that tubular structure running down here. We don't know where the tip is yet. Well, we do, it's right up behind the colon. The idea is to try and deliver the whole thing out into the wound. That makes everything much easier. So in situations like these, where you can't see the tip, you can amputate the base of the appendix first. So I know we're there, that's the base of the appendix. We can't seem to get the tip out because it's buried up behind the cecum. It's often easier to amputate it at the base first. So I put a clip through the mesoappendix, through what looks like an avascular part. Clamp the appendix. I'll just move that Babcock a little bit further down. So the first proximal squeeze of the clip is for where you're going to tie the appendix, and the second one is for where you're going to amputate it. So we've cut the appendix off flush with the clip. So you can see the mesoappendix here, between the appendix and the cecum approached at a slightly more unusual angle. Because normally you'd go from the tip, but we've cut it at the base. There's obviously going to be some vessels in here, which we want to buzz or ligate. It's difficult to ligate them at this angle. So there's the inflamed tip of the appendix. Could you hold on to that as well? Thanks. And just sort of slightly over that way. Yeah, that's better. Now, the views aren't great down this deep, dark hole, unfortunately, but you can see now that we've got the tip held onto the Babcocks, and we just diathermine all the way around it, separating off from the surrounding tissues. Appendicular artery. And there's the inflamed tip of the appendix that was causing us so much trouble, stuck up behind the cecum. You'll sometimes then find that there's some bleeding coming from the mesoappendix, which is then quite deep in the wound and not really deliverable. So you just need to look for the bleeding point, and here we're just transfixing the appendicular artery. We tied the appendix stump earlier on. I personally like to transfix it as well if I can. It's easy to tie it as we did before, but it's easy now to just put a clip on the stump and transfix it. Washing out after an appendicectomy is a bit contentious, particularly with laparoscopic appendicectomies, because there seems to be a higher rate of post-operative collections. But whether you do so or not is really a matter of personal preference. And if you are going to do it, just make sure you do it properly. So we're going to close the wound. First thing then is to try and close the peritoneum, which isn't essential for the integrity of the wound, but it helps keep everything else out of the way whilst you're trying to close everything up. Often to get the peritoneum, just grab a piece of the abdominal wall, lift it up, and the peritoneum comes into view. So back down to our abdominal wall muscles, you hold on to that. Down here we had our transversus abdominis, which is often difficult to reappose, but you can certainly get the internal oblique. And this stitch doesn't have to be tight. It can just be an approximating suture. You don't want the muscles to necrose, it's just to show them the way. So you can see the external oblique, upper and lower edge. So we have the external oblique layer closed now. Just have fat to close. We'll just put some betadine into that wound just to minimise the risk of wound infection. And it's optional whether you put any fat stitches in. If there's quite a lot of fat, you can just minimise the dead space by putting one or two interrupted sutures in. If there's been gross contamination, a lot of people would prefer to put clips in rather than a subcuticular stitch, as these are just easier to remove in the event of a wound infection.